the patient response to therapy was very good. With entrectinib, we know that these patients can stay on treatment for around 11 months. The progression-free survival is around 11.2 months. With larotrectinib, it was not published because the progression-free survival was still not achieved when we published the original publication. This patient, in this case, has been on the drug for 18 months. So that's why we can call this type of response as amazing and successful. And that's exactly what we're looking, because now that this patient is progressing, we can do another clinical trial with another TKI and hopefully buy more time before this patient has to start palliative chemotherapy. Also, I have to add that this patient had a response in the brain. That's another successful story, because as I said, it is changing the standard of care in the management of single or brain metastases. The study that called the approval of Floxo was very interesting. At the beginning, it was a phase 1 study for adults, then there was a study for children, and then it was a phase 1/2 study for adults and children, adolescents. Basically, with these uncommon genetic aberrations, we need to put together several studies because it's very hard even for one study to accrue because the incidence, the low incidence of these genetic aberrations. So that's why the original publication in the New England has 55 patients coming from 3 different studies. And the same happened with entrectinib. Entrectinib collect data that has been presented in several meetings for another 2 or 3 studies that were developed for this agent. These studies are revolutionary because, as we mentioned before, we're doing tumor agnostic therapy. The studies were not only for lung cancer patients or breast cancer patients or pancreas patients that we used to do. This study was a basket trial, meaning that we can have several different tumors enrolled in the study. And in the case of larotrectinib, there were 17 different types of tumors. And they were enrolled, as we mentioned before, for adults or children, regardless of age, because we allow children and adults. So this was very revolutionary design, very innovative, and I think very successful. In the case of the doses for these tyrosine kinase inhibitors, in the case of larotrectinib, it was not very hard to find the doses because they start testing 50 milligrams once a day and escalating the dose. And we ended only having 100 milligrams twice a day as the right dose because we already had responses at that level. And something similar happened with entrectinib. At these doses, the side effects are well tolerated. They are not life-threatening side effects. And we already see responses that can be up to 70% for each agent for solid tumors in general. So that's why with this amazing response, there was no need to continue increasing the doses for these agents. And in the specific case of lung cancer, larotrectinib also gives a response rate of around 70%, and entrectinib too. So that's why I think we deal very well with the doses. We mentioned before that maybe 9% of the lung cancer patients need a dose reduction. Maybe 27% of the entrectinib patients need a dose reduction. Very, very few patients need to discontinue the drug. In the case of larotrectinib, around 1%, entrectinib 4%. So that's why it was not very complicated. I think these TKIs are well-tolerated agents. It's not like the old times when we used to do dose escalation for chemo. There was a lot of toxicity. Nowadays, target therapy is something very different, to the point that in a lot of these biologic agents or target therapy agents, we don't even know what is the maximum tolerated doses because we have not need to reach that. you already have responses to a lower doses.